Contrast. I mean, you're looking
Mhm.
at a plain text bullet point, but that bowel and urinary health.
Right. And before you reach for the skip button, because talking about poop and pee isn't your idea of a good time, stick with us.
Yep, please do.
Because the argument these sources make is that this isn't just about waste disposal. We are actually looking at a gold mine of data.
It's the body's primary diagnostic engine. If you're a nurse or a caregiver, or honestly just someone who wants to understand their own physiology, elimination is the dashboard.
A dashboard. I like that.
Yeah, when the output changes, the color, the consistency, the frequency, the check engine light is essentially on.
And the stakes are surprisingly high, too. We aren't just talking about mild discomfort here.
No,
We're talking about the physics of fluid dynamics in the colon, cardiac arrest triggered by straining, and how, get this, a simple dehydration issue can look exactly like kidney failure if you don't know how to read the labs.
It is high-stakes plumbing, essentially.
High stakes plumbing. So let's start where the sources start, which is
Yeah.
the concept of normal. Because I feel like everyone has a very different definition of normal, and usually it's just based on whatever their own personal routine happens to be.
And that is exactly the problem. We tend to think normal equals daily. But clinically speaking, the window is massive.
How massive?
Well, the lecture material points out that for one person, going 3 times a day is their baseline. For another person, it's 3 times a week.
Wow.
And both of those are medically considered normal, provided the consistency is right and there's no pain.
I mean, 3 times a week sounds wildly infrequent to me. If I miss a single morning, I feel sluggish all day.
Sure, but the sources highlight a really interesting psychological element here, specifically with elderly patients in hospitals.
Oh, right. The loss of autonomy.
Exactly. This is a huge friction point in care. Think about the context for a second. You have an elderly patient admitted to a hospital. They've lost all control. They don't control when they eat, what they eat, when they sleep.
Or who comes into their room.
Right. The one routine they have governed for decades is their morning bowel movement.
It's like the last bastion of control.
Precisely. So when hospitalization disrupts that, maybe they're stressed, the food is different, the bed is weird, and they miss a day, they panic.
They think there's something horribly wrong.
Yeah, they perceive themselves as dangerously constipated, even if physiologically they're still well within that safe 3 times a week window.
So as a clinician, you're managing the patient's anxiety just as much as their actual physical state.
Definitely.
But if frequency isn't the best metric, what is? We have to look at the texture, right?
Texture and consistency. And for that, we rely on the Bristol stool chart. It is the gold standard.
I've seen this. It breaks stool down into 7 different types.
Right. So you have type 1, which is hard, separate lumps, like nuts.
And that's severe constipation.
Yes. And on the complete opposite end, type 7 is entirely liquid.
So we're aiming for somewhere in the middle.
The Goldilocks zone, type 3 or 4. Smooth, soft, formed, usually described as like a sausage or a snake. That tells us the transit time through the colon was just right. Enough water was absorbed to form it, but not so much that it became a rock.
And to get to that type 4, the sources lay out a sort of holy trinity of bowel health. It's not just one magic bullet. It's 3 factors that have to work together.
Fiber, fluids, and activity. And the interplay here is critical because if you mess up the balance, you can actually make things much worse.
Right. Let's break that down. Starting with fiber. The magic number mentioned is 25 to 30 grams a day.
Correct. Fiber provides the bulk. It distends the bowel wall slightly, which triggers the muscles to move. But here's the trap. Fiber works like a sponge.
It needs water.
It needs water to swell and soften.
And this is where the fluids part comes in. The sources were very specific about this. If you increase fiber but you don't increase water, what actually happens?
You are essentially manufacturing a concrete block inside the intestine.
Oh, man.
The fiber just sits there, it dries out, and it becomes a massive obstruction. You have to have that 2 to 3 liters of fluid daily to keep the sponge wet, so to speak.
Concrete block is a terrifying image.
It's a very accurate one, unfortunately.
And a third leg of this, pun intended, is activity. And I thought this was fascinating because it's not just the general advice of exercise is good for you. There is a mechanical reason why walking helps you go to the bathroom.
It's all about peristalsis.
The muscle contractions.
Right. Peristalsis is that wave-like contraction of the smooth muscle in your intestines that pushes the waste forward. It is involuntary, meaning you can't just will it to happen.
Right.
But physical movement, engaging the core, walking, taking deep breaths that move the diaphragm, all of that mechanically stimulates those nerves.
So when a patient is bedbound,
The wave stops. or at least it slows down to a glacial pace.
Wow.
Immobility is a primary cause of constipation. This is exactly why nurses are so aggressive about getting patients out of bed and walking the halls right after surgery.
It's not just to prevent blood clots.
No, it's to restart the gut.
Speaking of surgery, that brings us to the external disruptors. The hospital environment seems perfectly designed to stop you from pooping.
It really does.
You're immobile, you're stressed out, and then they pump you full of drugs. Opioids and anesthesia specifically.
They are the absolute enemies of peristalsis.
How does that mechanism actually work? Because we think of opioids as painkillers.
Well, opioids like morphine or oxycodone are fantastic at blocking pain receptors in the brain. But we also have opioid receptors in the gut.
Oh, I see.
So when the drug binds there, it essentially paralyzes the smooth muscle. It tells the bowel to just stop moving.
And anesthesia does the same thing.
Similar effect. The source material uses a great phrase for this. Anesthesia puts the bowels to sleep just like it puts the brain to sleep.
That makes total sense.
Yeah, so when you wake up from surgery, your brain is back online, but your gut might hit the snooze button for another 24 hours.
Which totally explains why, if you've ever visited someone post-op, the nurse always comes in with a stethoscope and just listens to their stomach for a solid minute.
They are hunting for bowel sounds, gurgles, and clicks. You cannot feed a patient solid food until you hear those sounds.
Because if you put food into a sleeping gut...
It just sits there, it won't move, the patient will bloat and eventually start vomiting.
Yikes. So let's look at the absolute worst-case scenario.
Yeah.
The system fully jams. We move from simple constipation, which is just uncomfortable, to something called fecal impaction.
Right, and we need to clarify this because impaction is a medical diagnosis. Constipation is a symptom. Impaction is an event.
Meaning there is a physical blockage.
Yes. It means there is a hardened mass of stool stuck in the rectum that the patient simply cannot pass no matter how hard they strain.
And there's a specific symptom of impaction mentioned in the notes that I found super counterintuitive. It's almost a paradox.
The oozing.
Yes, you have a massive blockage, but the patient might actually complain of diarrhea.
This confuses new nurses all the time. It is called paradoxical overflow.
Walk us through the physics of that. How does a blockage cause a leak?
Okay, visualize a cork stuck tightly in the neck of a bottle. That's the impaction. But the colon above that cork is still working, it's still processing waste, and it is desperately trying to flush that cork out.
Right.
So the body starts liquefying the stool higher up in the tract.
It turns it into liquid to try and lubricate things.
Exactly. And that liquid pressure builds and builds until it finally finds a way to seep right around the edges of that hard mass.
So it leaks out.
It leaks out of the rectum. So the patient is leaking liquid stool, but they are actually 100% blocked up.
And the danger here, as the sources point out, is if you misdiagnose that.
Oh, it's catastrophic. If you see the liquid, think, oh, they have diarrhea, and you give them an antidiarrheal medication to stop the motion.
You're just sealing the tomb.
You are making that blockage significantly, dangerously worse.
That is such a critical aha moment. You have to check for the blockage first. Yeah. And if there is a blockage, well, we have to get it out. Which brings us to the part of the job description that definitely does not make it into the glossy nursing brochures. Digital removal.
Manual disimpaction. It is exactly what it sounds like.
A nurse has to use lubricated, gloved fingers to manually break up and scoop out the hardened stool from the rectum.
It is not glamorous.
It sounds incredibly unpleasant for everyone involved, but the sources flag it as actually being dangerous. And this connects back to what we teased in the intro, the Elvis Presley connection.
Ah, yes. The vagal response. This is crucial physiology. The vagus nerve is one of the longest nerves in the entire body. It runs from the brainstem, down the neck, through the thorax, and branches all the way down to the colon and the rectum.
And what exactly does the vagus nerve control?
It's the primary driver of the parasympathetic nervous system. That's your rest and digest system. And one of its main jobs is to lower your heart rate and blood pressure.
So when a nurse is, for lack of a better term, digging around in the rectum,
you are mechanically stimulating that vagus nerve. You are essentially slamming the brakes on the heart.
That is wild.
So if a patient strains too hard on the toilet, which is called the Valsalva maneuver, or if a nurse is performing digital removal, that intense stimulation can cause the heart rate to drop precipitously.
Bradycardia.
Yes.
And if the patient already has a weak heart to begin with,
they pass out, syncope. Or, in severe cases, they can go into cardiac arrest. The prevailing medical theory with Elvis is that severe constipation led to extreme straining, which triggered a massive vagal response that stopped his heart.
You just don't think of the bathroom as a place where you need to worry about acute cardiac events.
It is actually a very common location for code blues in a hospital.
Wow.
That's why the protocol for digital removal isn't just go in and get it done, it's check vital signs first and continuously monitor. If the patient says they feel dizzy or if you see the heart rate dropping on the monitor, you stop immediately.
You have to respect the vagus nerve.
You really do.
Okay, so manual removal is the absolute last resort. Before we get there, we usually try to dissolve the problem or flush it out.
Right, the enema.
The liquid crowbar.
I've never heard it called that, but yes.
The sources go into a ton of detail about the physics of enemas, specifically the positioning of the patient, the left Sims position.
This is non-negotiable in practice. You have the patient lie on their left side with their right knee pulled up towards their chest.
And why is it always the left side? What's the difference?
It's just gravity and anatomy. The sigmoid colon, which is that final S-shaped curve right before the rectum loops down towards the left side of the body.
Oh, I see. So if you lay a patient on their right side,
You are trying to push water uphill against the natural anatomical curve of the gut. It won't go deep enough to do any good. By laying them on their left, you are pouring the fluid downhill directly into the sigmoid colon where the stool is actually waiting.
is simple hydraulics. Now, we need to talk about what we're actually putting in that enema bag, because not all fluids are created equal here, and some can actually hurt the patient if used wrong.
Absolutely. We categorize enemas by tonicity, meaning how the fluid interacts with the body's cells.
Let's start with tap water, because it seems like the most innocent, basic option, just warm water. But the source material has a strict warning, do not repeat. Why?
Because tap water is hypotonic. That means it has a lower concentration of salt and electrolytes than your blood does.
And osmosis dictates that water flows from a low concentration to a high concentration.
Exactly. So the water leaves the bowel and goes straight into the bloodstream. The body just sucks that water up like a dry sponge.
Okay, so one enema is fine, but if you do it again,
You are flooding the patient's circulatory system with extra water, which leads to water toxicity, circulatory overload. You're diluting their sodium levels and putting a massive strain on the heart to pump all that extra fluid.
So tap water is strictly one and done.
Right.
What's the safest option then?
Normal saline. It is isotonic. It matches the body's natural fluid balance perfectly, so it doesn't get absorbed into the blood, and it doesn't pull water out of the cells. It just sits there in the bowel, softens the stool, and stimulates evacuation.
And then we have the soap suds enema, which literally just uses Castile soap and water.
Yes. And I love the anecdote in the transcript where the student asks if washing the bowel with soap is toxic.
Right.
It's not toxic, but it works through pure irritation. The soap chemically irritates the delicate lining of the intestine.
It makes the gut angry.
It does. It triggers a violent muscle contraction to get the irritant out. It is very effective, but it almost always causes cramping.
Which leads perfectly to the golden rule of enemas mentioned in the sources. You're administering the fluid, the bag is hanging on the IV pole, and the patient suddenly yells, "I'm cramping." What is the immediate move?
The instinct for a lot of people is to pull the tube out and stop entirely. Don't do that. The move is simply to lower the bag.
Just drop it down.
Yes. The height of the bag determines the pressure of the flow. It's just gravity. If the bag is hanging high up on the pole, the water is rushing in like a fire hose.
Makes sense.
If you lower the bag down below the level of the patient's hips, the flow stops. The pressure drops. It might even reverse a tiny bit.
So you're basically using gravity as a throttle.
Exactly. You lower the bag, the flow stops, the cramping subsides, then you slowly, carefully raise it back up. You completely control the patient's comfort just with the height of the bag.
I love that. It is such a practical, low-tech solution. Okay, let's pivot to the complete opposite problem, when the system is moving way too fast.
Diarrhea.
The green apple splatters, as one of the sources colorfully put it. Obviously, the massive risk here is dehydration, but there is a specific villain that haunts hospitals that we need to talk about.
Yeah.
C. diff.
Clostridioides difficile. This is a nasty spore-forming bacteria, and the tragic part is it's almost always an inside job.
Meaning healthcare workers cause it.
Often, yes. We give a patient strong, broad-spectrum antibiotics to treat an infection, say pneumonia or a urinary tract infection. Those antibiotics are like a nuclear bomb in the gut.
They kill the bad bacteria, but they also wipe out all the good gut flora.
Exactly. The neighborhood watch is completely gone, and that allows C. diff to move in, take over, release toxins, and cause severe, watery, explosive diarrhea.
And the sources mention the smell.
Oh, if you know, you know.
They were very specific about that
It
phrase.
is entirely distinct. It's not just a typical bad bathroom smell. It is a sickly, sweet, rotting, horse stable kind of odor. Veteran nurses can literally diagnose a C. diff case from out in the hallway just by sniffing the air.
That is a superpower I'm not sure I want. Now, usually with diarrhea, the standard advice is to avoid dairy, right? Milk makes it worse. But the sources make a very specific exception for yogurt. Why is that?
Because yogurt contains live, active cultures, probiotics.
Huh?
Since the root cause of C. diff is the lack of good bacteria, eating yogurt actually helps reseed the gut. It's one of the very few times dairy is genuinely medicinal.
And if yogurt isn't an option, they suggest the brat diet,
The absolute classic. Bananas, rice, applesauce, toast.
the beige diet.
Right. Low fiber, low residue, highly binding. It gives the gut a chance to rest and recover while still getting some basic calories into the patient.
Let's shift gears a little bit. We've talked a lot about the solid waste, but the sources also focus heavily on the liquid side, urine.
Yes, the lab work.
Right. And they clarify that nurses collect the samples, but the lab runs the machines. We just need to understand the numbers. And the two big ones are creatinine and BUN.
BUN, blood urea nitrogen. This is where we have to put on our detective hats because people get these two mixed up constantly.
Okay, yay it out for us.
Think of creatinine as the reliable witness. It's a waste product from normal muscle breakdown. Your kidneys filter it out of your blood at a very steady, predictable rate.
So if the creatinine level in your blood is rising,
Your kidneys are failing. End of story. The filter is broken.
okay, so creatinine is the red alert. What is BUN then?
BUN is the flaky witness. It measures nitrogen in the blood. Yes, it goes up if your kidneys are failing, but, and this is but it also goes up if you are simply dehydrated.
Interesting.
It goes up if you eat a massive steak dinner. The source even jokes about nursing students having high BUN because they've been chugging energy drinks all night.
So a high BUN doesn't automatically mean kidney failure.
Not at all. You have to look at them together in context. If the BUN is high, but the creatinine is totally normal, you probably just need to drink a liter of water. You're just dry.
But if both of them are high,
Then the kidneys aren't filtering. That is true renal insufficiency.
it's all about the context.
Man.
Finally, I want to tackle a topic that is profoundly life-changing for patients and honestly requires the absolute most empathy from caregivers. Ostomies.
This is a massive adjustment. This is when the plumbing is surgically rerouted.
The surgeon brings a piece of the actual intestine right through the abdominal wall to create a stoma.
Right. So waste exits into a pouch worn on the stomach instead of going down through the rectum.
The sources distinguish between a colostomy and an ileostomy. And it's not just a geographical difference of where the stoma is located. The actual output is completely different.
And that comes right back to the core function of the intestine. The large intestine's main job is to absorb water from the waste. So, if a patient has a colostomy, which is located in the large intestine, near the end of the stool has already traveled through most of the gut. The water has been absorbed, so the output is solid or at least semi-formed.
But an ileostomy is different.
An ileostomy taps into the small intestine, the ileum.
So the water hasn't been absorbed yet.
Exactly. The output is constant acidic liquid.
Which means a patient with an ileostomy is at a huge risk for dehydration.
A massive risk. They are literally pouring fluid out of your body all day long into that pouch. They have to drink water constantly just to keep up.
What about the stoma itself, the exposed tissue? The text uses a very specific phrase, beefy red.
That is the actual clinical term we use. It should look like the inside of your cheek. Moist, shiny, red, highly vascular. That means it has excellent blood flow.
And what if it's not? What if it's pale or purple?
That is a drop-everything surgical emergency. A purple or black stoma means the tissue is dying. The blood supply has been compromised or cut off. You have to call the surgeon immediately.
Living with an ostomy. There are these daily maintenance issues that I frankly never even thought about until reading this. Specifically, burping the bag.
It's a reality of human digestion. Just because a patient isn't using their rectum anymore doesn't mean they start producing gas.
Because the bacteria in the gut are still fermenting the food.
Exactly. And that gas has nowhere to go but out the stoma, and it fills up the ostomy pouch.
Like a balloon.
Just like a balloon. And if you don't manually open the valve and release that gas, literally burp the bag, The pressure will just build until the adhesive seal breaks. The entire bag can pop right off the abdomen,
Which would just be a catastrophic mess.
and psychologically completely devastating for the patient.
The psychological impact cannot be overstated. The sources talk openly about the odor, the constant fear of a leak, the severe body image issues. Imagine sitting at a restaurant or at your desk at work, terrified that your bag might smell or suddenly detach. It takes a huge amount of adjustment and empathy.
But there's a silver lining mention that I found really encouraging. These aren't always a permanent life sentence. That's a really important point to end on. Many ostomies are temporary. Let's say a patient has a gunshot wound to the abdomen or a severe bowel perforation.
The surgeon creates the ostomy just to divert the flow of waste.
Right, which allows the injured lower part of the bowel to rest and heal in a clean environment for a few months.
It's literally like setting up a detour sign during road construction.
That's a great analogy. Once the healing is done, they go back into surgery, reconnect the plumbing, and close up the stoma. It is truly amazing that the human body can handle that kind of extreme reconfiguration.
It really is. So we've covered a massive amount of ground here today. From those stark, black and white PowerPoint slides to the hidden risks of the vagus nerve, the gravity physics of enemas, and the distinct chemistry of C. diff.
And if there's one overarching takeaway for you listening, it's that elimination is a language. The body is constantly talking to us through these very specific outputs.
The dashboard.
The dashboard. Whether it's the color of a stoma, the specific gravity of the urine, or the texture on the Bristol stool chart, it's telling us real-time data about hydration, infection, and major organ function. We just have to be willing to look at it and listen.
But before we officially wrap up, I do want to leave you with one final, slightly provocative thought pulled from the source material. We live in this culture of immediate quick fixes.
Oh, absolutely.
You feel bloated? Take a pill. Not regular this week, just take a laxative. But the sources included a pretty stern warning about exactly that instinct.
Chronic laxative abuse. It is a massive hidden problem.
Because what happens if you rely on them too much?
It's the law of unintended consequences. If you are constantly stimulating your bowel with harsh chemicals to force it to move, the smooth muscles actually get lazy.
They forget how to do the work themselves.
They lose their natural tone. They stop responding to the body's own internal signals.
So by desperately trying to force regularity with a quick fix, you can actually end up causing chronic, severe constipation.
You essentially break the exact mechanism you were trying to fix.
Which really makes you wonder, in our modern quest for convenience and instant relief, how often are we fundamentally disrupting our body's natural rhythms just because we don't have the patience to drink some water and take a walk?
I think the clinical answer is, unfortunately, far too often.
Definitely something to think about the next time you're standing in the pharmacy aisle looking for a quick fix. Well, thank you for diving deep with us today into the messy, critical, and frankly fascinating world of elimination.
It was a great discussion.
We'll catch you on the next deep dive.